Good morning, Slow. Thank you. So Mpox, I'm not just being lazy by not calling it by the other name, monkeypox. We've actually changed the nomenclature so that it is not considered a disease of monkeys at this point. It started in 1970 when there were some original cases in monkeys in the Democratic Republic of Congo, but we actually have not seen it in monkeys in a long time. We have seen it in lots of rodents in endemic countries. 11 countries in Africa is where it's been. And only one other time in the United States, 2003, was a small outbreak of 70 cases, but mostly it's been a disease that's been endemic to Africa, and now we're seeing an explosion. So why is that? Well, for one thing, it is a cousin of smallpox. Smallpox eradicated in the late 70s. Most people above the age of 45 have been immunized, and so there is some cross protection. So we are seeing it in younger age groups, as you'll hear. But as to why this particular case has taken off so globally, we're really not sure. Transmission, though, is as follows. It's really close skin-to-skin contact, intimate contact. It can also be transmitted by clothing, bedding, linens, towels, cups, utensils, etc. So, but for the most part, it's skin-to-skin. The jury is still out on whether or not it can be transmitted respiratory wise, but the thinking is that it cannot. And it certainly isn't like that other disease that will go unnamed by me today. What is this disease? It is, for the most part, a skin disease, but it starts as any other flu-like syndrome. So usually after contact, 5 to up to 3 weeks after contact is when you can get the disease. It starts with fever, headache, chills. The one finding that is unique with this among flu-like symptoms is that often you get lymph node swelling. So that sometimes can be telltale, but for the most part, it looks like anything else, and you can't tell until you get the rash lesions. And that is what is really symptomatic of this disease. I'll name all the different things that you never learned in dermatology school. So it starts out as macules, which are flat, red-like lesions. It goes on to papules, which are raised lesions. It then goes on to vesicles, which are clear fluid filled lesions, and then it goes on to pustules, which are yellow liquid. I know we've all had breakfast. I see some chuckles. I'm sorry. I'm a doctor. And then ultimately those lesions crust over and the crusts fall off, and that's how you get clear of the disease. For the most part, treatment is just supportive, lots of fluids, lots of good nutrition, rest. But for some people, they really can get severe disease. Those who are at risk severe disease, especially if it gets into sensitive places like the eyes or the anogenital area, treatment is really recommended, and that treatment is an antiviral medication called tecovirimat or TPOXX. But for the most part, people are doing well with this disease. There is a laboratory test for it. That's how we know ultimately that it is this disease and not something else. And so let me give you a little bit of epidemiology about what's been going on. Globally, there are now more than 62,000 cases. In the United States, we're just under 24,000 cases. And in the state of California, we're at about 4,800 cases. We're lucky here on the Central Coast, and in our county, we've only had one confirmed case. In our region, we test up and down the coast. We've had 38 cases in Ventura County, Santa Barbara County, and us. But over half of the cases have been in Los Angeles and San Francisco. The average age is 38. And as I mentioned, most people, or 78% of the cases, have been in those under the age of 45. We've seen disproportionate impact in people of color. So Black, African-American, and Hispanic Latino communities have borne an unfair burden of this disease as well. And overwhelmingly, it's a disease of men. This particular epidemic that we're seeing, 97% have been in men. And of those, 93% have been in gay, bisexual, and trans men. So we're seeing a really disproportionate burden in that community. but still it can affect anyone. So don't be, cavalier about it. 8 to 10% of all cases have been non-sexual transmission, and there have been 8 cases in children. So what are we doing about it? What are the prevention messages? Certainly being aware of who you're having intimate contact with and whether or not they have any symptomatology is the most important thing. Avoid close and intimate contact with anyone who has symptoms. Vaccination is also available to those who are at high risk, and we have done some vaccinations in our community. We very proudly partnered with Gala Pride and Diversity Center. We did over 100 vaccines in our community there. We did in North County additional vaccination efforts, and we're coming up on one in Cal Poly. So also avoid sharing items. This is something that we do to prevent any disease, but with this one is also very important. So how is this going to end? I hope before too long. We are seeing the epi curve, as we call it. The number of diseases went way up over the summer, and now it's beginning to come down. And the last thing I want to mention is a scientific construct called the R effective rate. So what you need to see for an epidemic to go away is that less than 1 person per case is infected, so that you can get, from the number of people who currently have it to a lower number, and eventually that it will die out. We are now, through the past week, seeing for the first time the R effective rate below 1. And so that's what you need to see, is that going down so that new cases are not cropping up at the same rate as your existing cases. So I was a bad predictor of what COVID was going to do, but monkeypox, I think, will leave our communities within months, and I hope that's the case. And but in the meantime, be aware, be careful, and I hope that this education was a bit of interest for you, and go slow. Thanks.